considerations for carotid endarterectomy. My name is Major Darrell Saylor with the Uniformed Services University of the Health Sciences Nurse Anesthesia Program, summer semester of 2014. We will be reviewing the description, incidence, mortality, morbidity, and symptomology of carotid endarterectomy procedures, including general vascular considerations, preoperative assessment of the disease process, including general and specific considerations, intraoperative management, and intraoperative and postoperative complications. The carotid endarterectomy, or CEA, is the surgical treatment of symptomatic carotid artery stenosis. Strokes and transient ischemic attacks, or TIAs, resulting in carotid artery stenosis occur as a result of a thorough emboli or hemodynamic pressure drops across the stenosis without sufficient collateral cerebral blood flow. The positioning for this procedure is going to be supine with neck extended and the head turned away from the side of the lesion. Operating time is approximately 90 minutes with an estimated blood loss of 100 to 200 milliliters. The ratio of male to female is 3:1. Indications for the surgery: for open surgery or endovascular interventions, including TIAs associated with ipsilateral severe carotid artery stenosis greater than 70% occlusions, severe ipsilateral stenosis with minor or incomplete stroke, and 30 to 70% occlusions with ipsilateral symptoms with usually ulcerated plaque. Historically, CEA was recommended for asymptomatic patients with lesions greater than 60%. Currently, stenting would be the recommendation. CEA significantly lowers the stroke risk in comparison to medical management in males with severe carotid artery stenosis of 70 to 90%, and modestly reduces stroke with 50 to 69% luminal narrowing. Risk reduction in stroke is small, around 1% per year for the first few years, but then increases with long-term follow-up. As far as incidence, approximately 3% of adults have experienced a stroke. Stroke is the leading cause of disability and the third leading cause of death in the United States. Approximately 80% of these strokes are ischemic. Figure 6.3-1 on the left side shows exposure to the carotid bifurcation. In addition to the vascular structures, take note of the vagus and hypoglossal nerve and their respective areas. On the right-hand side, figure 6.3-2, you'll notice figure A shows the clamping of the carotid artery, B shows placement of a shunt, and C is separation of the plaque from the carotid artery. After 5 years, ipsilateral and any stroke or death was estimated to be 11% for patients treated medically and 5.1% for surgical patients. There's a benefit to CEA over medical therapy for asymptomatic stenosis only when both the perioperative risk is low and the patient is expected to live more than 10 years. Operative mortality is 1 to 4% and is primarily due to myocardial infarction. Perioperative morbidity is 4 to 10%, principally neurologic caused by strokes and increased with pre-existing neurologic deficits. Increased operative risk is seen with patients of age greater than 75 years, symptomatic lesions, uncontrolled hypertension, angina, carotid thrombus, and occlusions near the carotid siphon. Symptoms for carotid endarterectomy are classic transient ischemic signs, or TIAs. Manifestations include amaurosis fugax, which is a transient monocular blindness caused by an emboli in the ophthalmic artery. Also seen are episodes of paresthesias, uncoordination or weakness of the extremities, and speech problems. Usually spontaneous resolution is seen after a short period. Cervical bruit on the affected side may also be present. General vascular preoperative considerations. Starting up the left with cardiac risk stratification, 2007 the American Heart Association and American College of Cardiology revised their guidelines. Under these guidelines, clinical predictors of increased perioperative cardiovascular risks, such as myocardial infarction, congestive heart failure, and death, are classified as major, intermediate, and minor. And we will look at this closer with subsequent slides under figure 39-5. Under perioperative coronary revascularization, there is controversy as to whether preoperative coronary revascularization protects against perioperative cardiac events. The Multicenter Coronary Artery Revascularization Prophylaxis Trial, or CARP, looked at randomized patients with coronary artery disease before elective vascular surgery and found no benefit to coronary revascularization. A subsequent subgroup analysis of the CARP trial studied coronary artery bypass grafting, or CABG, versus percutaneous transluminal coronary angioplasty, or PTCA. The CABG patients had fewer MIs and spent less time in the hospital after vascular surgery than those having PTCA. Preoperative coronary revascularization may have no benefit for the prevention of adverse events except in patients where revascularization was indicated for acute coronary syndrome. The safe time interval before vascular surgery is 4 to 6 weeks for surgical coronary revascularization and 2 weeks for coronary angioplasty. For stents, it is much longer depending on type, and we will look at that further under Figure 121-3. Prevention of myocardial injury covers prophylaxis treatment preoperatively, and we'll look at that in Table 39-2 subsequently. Optimization of medical problems. Two main medical problems we want to optimize before carotid endarterectomy surgery. One is hypertension. This should be corrected gradually over days to weeks to allow for normalization of endovascular volume and cerebral autoregulation. Diabetes mellitus is common in vascular patients and also predicts perioperative myocardial ischemia. Diabetic patients generally have a higher risk of myocardial infarction and wound infection. Abnormal sugars should be corrected prior to surgery. Hypercoagulable states. These are more common, according to literature, in younger patients and in patients with vascular thrombi in unusual sites. Postoperative abnormalities may show elevated fibrinogen levels, antithrombin 3 deficiency, impaired fibrinolysis, and protein C and S deficiency. Under anemia, this was classified as an independent predictor of adverse short and long-term cardiac outcomes after vascular surgery. Transfusion worsens important outcomes, including survival after vascular surgery. In one study, beta block patients did not tolerate surgical anemia when compared with other patients. It may be prudent to maintain sufficient hemoglobin levels in beta block patients. This table outlines risk stratification. Aortic and peripheral vascular surgery are in the high-risk surgery category at 5% risk. This means MI or cardiac-related death. Carotid endarterectomy and most endovascular procedures are in the intermediate risk category with a cardiac risk of 1 to 5%. Figure 39.5 shows cardiac evaluation care algorithm for non-cardiac surgery based on active clinical conditions, known cardiovascular disease or cardiac risk factors for patients 50 years of age or greater. Following the algorithm under Step 1, you ask whether there is a need for emergency non-cardiac surgery. If the answer is yes, you're going to obviously proceed to the emergency room and perform risk factor management during the surgery. If the answer is no, then you have to decide whether the patient has, under Step 2, active cardiac conditions. These active cardiac conditions include acute MI, less than 7 days, recent MI of 7 to 30 days, unstable angina, decompensated CHF, severe valvular disease, and significant dysrhythmias. These conditions will require intensive management. You will then evaluate and treat per guidelines and then consider the operating room. Next, under Step 3, if they don't have active cardiac conditions and they're low-risk surgery, if that's the case, then you'll proceed with surgery. If they're not low-risk surgery, but they have greater than 4 METs, then you'll proceed with the surgery. If they don't have greater than 4 METs, or you're not sure if they do, you look at their clinical risk factors. Now, clinical risk factors include ischemic heart disease, to include current or prior angina, and a history of MI. Other conditions include past or compensated CHF, diabetes, renal insufficiency, or cerebral vascular disease. Minor predictors are age greater than 70 years, abnormal EKG, rhythm other than sinus, and uncontrolled hypertension. So in our case, for carotid endarterectomy, you would follow, if they had 3 or more clinical risk factors in their intermediate surgery, you would proceed with the planned surgery with heart rate control. And if they have 3 or more factors going for risk factors going for vascular surgery, you would then look at whether or not could consider testing only if it would change the management. Same thing going down to 1 or 2 clinical factors. You look whether it's intermediate risk surgery and vascular surgery in our case, and you proceed with heart rate control and consider non-invasive testing if it would change the management. And then under no clinical risk factors, you would just proceed with the planned surgery. Figure 21-3 shows PCI or percutaneous coronary intervention management for non-cardiac surgery, depending on whether they had balloon angioplasty, bare metal stents, or drug-eluting stents. If they had balloon angioplasty and it's been less than 14 days since their surgery, you're going to delay for elective or non-urgent surgery. Greater than 14 days, you will proceed to the operating room with aspirin. Bare metal stents, greater than 30 to 45 days, proceed with aspirin. Less than 30 to 45 days, you would delay for elective or non-urgent surgery. Drug-eluting stents, less than 365 days, you would also delay for non-urgent. And then greater than 365 days, you would proceed to the operating room with aspirin. Table 39.2 Shows the pharmacologic prophylaxis against acute vascular events in patients undergoing vascular surgery. First, we need to look at what different class recommendations are. Just as a reminder, a Class 1 recommendation refers to conditions for which there is evidence or general agreement that a given procedure or treatment is useful or effective. Skipping down to a Class 3 recommendation, this refers to conditions for which there is evidence and general agreement that the procedure or treatment is not useful or effective, and in some cases may be harmful. Class 2 recommendations, those are A and B, fall in between and indicate conditions for which there is conflicting evidence or divergence of opinion about the usefulness or efficacy of the procedure or treatment. AHA guidelines and perioperative blockade. These are Class 1 recommendations indicated for patients previously taking beta blockers, and a Class 2A recommendation where beta blockers are titrated for heart rate and blood pressure while they're undergoing the surgery. For beta blockers, you can initiate oral therapy 7 to 30 days out before with either atenolol 50 to 100 milligrams daily or metoprolol 25 to 50 milligrams. Clonidine is considered a Class 2B recommendation. It's been shown to reduce intraoperative myocardial ischemia and catecholamine levels as measured on the first postoperative day. It's recommended for transdermal clonidine 0.2 milligrams per day initiated the night before surgery, or 0.3 milligrams oral clonidine administered 60 to 90 minutes before surgery. HMG-CoA reductase inhibitors or statins are considered a Class 1 recommendation, are used for primary prevention of perioperative MI in vascular surgery patients. Ideally, you would start these 45 days before surgery. There is a warning that discontinuing statin therapy for greater than 4 days after a major vascular surgery is associated with increased postoperative cardiac risk, so you want to resume those early right after the surgery. ACE inhibitors, usually cardizem, are considered Class 2B. They also have beneficial actions with regard to acute vascular events independent of their antihypertensive action in vascular surgery. There are negative implications for use that include its potent hypotensive effects. In contrast, however, dihydropyridine calcium channel blockers have been linked with increased perioperative mortality in some studies. Nitroglycerin is considered a Class 3 recommendation and may cause hypotension with reflex tachycardia, especially in the beta block patient. Prophylactic nitroglycerin should not be implemented for cardioprotection in these patients, although you would have nitroglycerin available for intraoperatively during the surgery. In addition to the aforementioned general vascular considerations, you want to define pre-existing neurologic deficits. Such as change in head position and its effect on cerebral function should be examined. Extreme head rotation, flexion, or extension in patients with vertebral carotid artery disease can produce compression of the artery. Assessment allows for these head positions to be avoided while the patient is under anesthesia. You also want to look at any other deficits, such as weakness in one extremity or the other, any visual deficits, any irregular pupils, any speech deficits. Number 2, optimizing the patient's clinical status according to their coexisting diseases. Again, uncontrolled perioperative hyperglycemia can increase morbidity by enhancing ischemic cerebral injury, so you want to correct any abnormal blood sugars. It's beneficial to establish the usual range of blood pressure for the patient preoperatively to provide a guide for acceptable perfusion pressures during anesthesia and surgery. Angina should be stable and controlled. In addition, CHF symptoms should be absent. Because most patients are elderly, and enhanced sensitivity medication should be expected. If surgery is performed before coronary revascularization, it could result in significant death from cardiac causes. The contrary argument to this, though, is that stroke is more common if coronary revascularization is performed first. Due to insufficient guidelines, you must individualize to the patient and consult with the surgical team. Perioperative MI was 2.3% in symptomatic patients who underwent CEA in the carotid revascularization endarterectomy versus stenting trial, or CREST trial. Number 3, aspirin should be continued throughout the perioperative period. Many patients will also be taking additional antiplatelet therapy. This must be balanced against the risk of bleeding. Perioperative Plavix is a risk factor for post-CA bleeding, especially if it's continued up to the day of surgery. It is recommended to stop Plavix 5 days before surgery. Chronic antianginal, antihypertensive, and antiplatelet medications are usually continued to the day of surgery with the exception of Plavix as noted above. Number 4, preoperative sedation should be restricted to the smallest effective dose. Now getting into intraoperative management, we're going to look at the benefits and disadvantages of general anesthesia versus regional anesthesia. Under general anesthesia, the focus should be on maintenance of hemodynamic stability and prompt emergence for immediate assessment of the neurologic status. Advantages for general anesthesia include control of the airway and ventilation, optimized surgical conditions in the surgical field. Disadvantages include indirect monitoring of cerebrovascular status and hemodynamic instability. Regional anesthesia is performed using a superficial cervical plexus block